So Joanna Moncrieff is a senior lecturer at University College London and a consultant psychiatrist. She's known for her controversial work on the nature of psychiatric drug treatment, suggesting that psychiatric drugs, like other psychoactive substances, create rather than reverse abnormal brain states. And she has written on the history and politics of psychiatry and the pharmaceutical industry. She is the co-chairperson of the Critical Psychiatry Network, which has campaigned against the increasing influence of the pharmaceutical industry and the extension of psychiatric coercion. She is the author of The Myth of the Chemical Cure, a straight-talking introduction to psychiatric drugs, and she has a new book coming out soon at the end of the year called The Bitterest Pills, which is a critical history of antipsychotic drugs. Please help me in welcoming Dr. Moncrieff.
Okay, thank you very much, Anwar, for inviting me. It's really a great honour to be here and to be part of this programme, this really inspiring programme which is taking the university out to the wider community, something that I'm going to go back and try and emulate in some way back at home in London. And thank you all for coming and struggling through the snow. I guess you're more used to it than me, but it's quite considerable amount of it out there still. So, right, just let me get the things going, right. So that's the book that most of this talk's going to be based on, although I'm going to give you some updates and bring in some material that I've been looking at for my new book as well. And what I wanted to say, really, this is a global humanities programme. This is going to be a talk that's quite a bit of it is about scientific subjects, but what I hope to show you and to demonstrate through this talk is how important it is to take a step back from what are presented as scientific facts, because only when we examine the social and political forces behind them, behind what is presented as science, do we sometimes realise how what are presented as scientific facts are in fact shaped by social and political factors. And what I think this illustrates is one of the theses of Michel Foucault, the French philosopher, who claimed that knowledge is power and power is knowledge. So knowledge legitimizes powerful groups, and powerful groups are able to establish what is taken for granted as knowledge. And he, in fact, used psychiatric knowledge and psychiatric power to illustrate this thesis. So, first of all, let's just think about the current situation that we live in respect to drugs that are prescribed for mental health problems. So what I'm going to be talking about mainly here are drugs like antidepressants, antipsychotics, benzodiazepine, drugs like Valium, Librium, Xanax, drugs that are called mood stabilizers like lithium and Depakote or valproate. And I got all the data out on prescriptions for these different sorts of classes of drugs recently because I knew that there'd been a massive increase in prescribing of antidepressants. But what I didn't know was whether people had just shifted onto antidepressants from something else or whether there'd been an overall increase. Anyway, it turns out that overall there has been an increase because although prescriptions for hypnotics and anxiolytics, that's drugs like the benzodiazepines, haven't changed very much, the prescriptions of antidepressants and other things have gone up considerably. So that increase hasn't been compensated for by a decrease in anything else. And this increased consumption of these medications has been associated very strongly with a message that what they are doing is rectifying an underlying chemical imbalance. And this is a message that's been promoted particularly by the pharmaceutical industry. I like this picture because it represents the balance. You see the woman in the very balanced position. And these statements taken from the Geodon website are very typical of statements that are made about all sorts of psychiatric medications at the moment. The idea that they balance brain chemicals which are imbalanced in mental disorders of certain types. So what that sort of idea epitomizes is the mainstream view, the mainstream understanding of what psychiatric drugs do, which I've called, in order to try and understand both the mainstream view and how we might think differently about what psychiatric drugs do, I've formulated these different ideas into models. So I've called this mainstream view the disease-centered model of drug action. And this is the idea, as I said, that these drugs are working by correcting an underlying abnormality. And it's an idea that's borrowed from general medicine, where most drugs are also understood to act in that way. But it doesn't necessarily mean that the drug is targeting the cause of the disorder. So, for example, insulin in diabetes might be a drug that you think of as working in this way. It's not treating the cause of diabetes, but by replacing the deficient insulin supply, it's helping to normalize, it's helping to rectify the underlying abnormality, helping to normalize the body. So the other way that we can think about what psychiatric drugs might be doing is what I call the drug-centered model, and I've called it this to emphasize that these drugs are drugs, that is, substances that alter the way that the body functions. And what I'm suggesting in this model is that far from working by normalizing the body, these drugs are working by creating an abnormal or altered state. And because they are a special sort of drug called psychoactive drugs, that is, they work on the brain and therefore they alter feelings, thoughts, emotions, and behavior, the altered states they create interact with the symptoms or problems that we call mental disorders. And sometimes these altered states may be useful in someone who is suffering from a deep depression or an intense psychotic state. But it's not that anything's been normalized, it's that the altered state the drugs create may be preferable to the mental experiences that they're having at the time. So an example of this way of thinking about drugs that's maybe not too controversial is the idea that alcohol is useful for social anxiety disorder, which was something I was taught when I was training, just in case you think that I'm just bringing that in. So the idea was not that alcohol corrected a chemical imbalance or obviously that it replaced an alcohol deficiency. The idea was that the characteristics of alcohol intoxication, which we're all familiar with, include becoming socially less inhibited, which can be useful for someone who is who finds social situations difficult. Another example, which I think helps clarify the difference, is the effect of opiate painkillers, so things like morphine. So morphine and opiates in general have a direct action on pain pathways, on the neurological fibers that conduct pain. They slow down the conduction in those fibers. And to that extent, they have a disease-centered action. But they also are psychoactive substances that create an altered state that typically is characterized by a state of emotional indifference or emotional detachment. So people who have taken opiates for pain often say that they still have some pain, but they don't care about it as much. And that aspect of their effects is a drug-centered effect. So, what am I pointing at? There we are. So just to recap then, so what this alternative model is suggesting is that psychiatric drugs are psychoactive substances, and this is sometimes forgotten, so this is just why I'm putting this slide up. There is no fundamental difference between them and other psychoactive substances. The ones we're familiar with, of course, are the substances that are used recreationally. The difference might be that most psychiatric drugs produce states that are not particularly pleasant. But that doesn't mean that they're fundamentally different in any way. They still, like all drugs, alter the body. And like all psychoactive drugs, because they work on the brain, they produce altered mental states as well. And like all drugs, they produce tolerance. That is, the effects that they have initially don't necessarily last because the body adapts to their presence. And for the same reasons, you get withdrawal symptoms when they're stopped. And like other psychiatric drugs, like other psychoactive substances, the state that they produce means that people are not necessarily very good at judging how they're functioning when they're under the influence of the drug. What someone called Peter Breggin, an American psychiatrist, has called a process of spellbinding. We're familiar with that with alcohol, for example, aren't we? That we're not necessarily very good judges of what we can do when we're intoxicated with alcohol, which is why there are drink driving laws, of course. Okay, so that's just an introduction, really, to different ways of thinking about psychiatric drugs. And now I want to just go into the history of these ways of thinking and show you how we got to the position today where the mainstream view, where most people accept a disease-centred model and have forgotten, really, that psychiatric medications could be understood differently. So at the beginning of the 20th century, most psychiatric treatment took place in asylums, like this typical Victorian asylum outside London. And there was very little emphasis on treatment because basically it was thought that there wasn't very much you could do for people who entered an asylum with insanity, as it probably would have been called at that time. As far as treatment was concerned, it was normally thought of to be non-specific, consisting of fresh air, a healthy environment, putting people to work when they were able to. There was a little bit of experimentation with physical therapies. There was a brief fashion for surgery because there was an idea that maybe madness was caused by chronic infection. So there was a fashion for removing people's teeth and sometimes other parts of them. But there was nothing in widespread use that was actually thought of as a specific treatment. Plenty of drugs were used throughout the first half of the 20th century, mostly sedative drugs like the barbiturates, but from the 1930s, stimulant drugs like amphetamines and benzodrine started to be introduced. And they were generally understood to work according to that implicitly, because there was very little discussion about them, very little interest in them, but implicitly they were understood to work according to that drug-centred model. So stimulants were thought to maybe pep you up a bit if you were a bit depressed, make you look a little bit more sassy. And sedatives like the barbiturates were thought to help you sleep or to relax you if you were highly anxious. But as I said, there was really very little official or academic interest in drugs or in treatment of any sort. But this started to change with the introduction of a series of physical treatment procedures, starting in the 1920s with the introduction of malarial therapy for syphilis. So a lot of people in these asylums at that time would have had chronic neurological syphilis. And there was an idea that if you gave them malaria, the high temperatures that the malaria caused would kill off the organism that caused the syphilis. It was obviously quite a dangerous treatment. And to this day, there's no real consensus as to whether it did any good or not. But it did start to change the atmosphere in psychiatric institutions. Staff there started to feel that there was something that they could do, something properly medical that they could do. From the 1930s onwards, a range of procedures were introduced for people with diagnoses like schizophrenia and manic depression, starting with something called insulin coma therapy in the 30s, which was introduced as a treatment for schizophrenia and consisted of giving people large doses of insulin, putting them into a coma, which lasted several hours, and then giving them an injection of glucose to wake them up out of the coma. Also a very dangerous procedure, as you might expect, with a death rate of about 5 to 10%. And then, of course, there was ECT. This is from Homeland, which I've been enjoying. And ECT, again, was introduced for the treatment of schizophrenia, but gradually it became to be associated more with the treatment of depression and manic depression. Now, the important thing about these two sorts of treatment is that they came to be seen as specific treatments for schizophrenia and manic depression, respectively. Insulin coma therapy was described a few years after it had faded out of use, really, as the decisive step from a purely symptomatic to a curative therapy of the psychoses. No one knew how it worked. There were various speculations, but it was nevertheless felt to work by acting on the underlying problem that was causing the symptoms of schizophrenia. And similarly with ECT, which